We've now got Mr. Jonathan Riley, consultant obstetrician and gynaecologist, cancer lead at Bolton NHS Trust, and he's going to talk to us about the BGCS ovarian cancer guidance and specifically what's new and how to implement it as a unit lead. Thanks.
I'm just going to have to make sure my crutch doesn't fall over. It normally does. So thank you, Amy, for introducing me. And yeah, I'm going to talk about the ovarian cancer guidance update, which was published last year. I'm just going to go through a bit of a background, just kind of a look over what the kind of key updates, particularly from a cancer unit perspective, looking about how that guidance can and should be implemented, and the challenges that we can face with that implementation. As well as looking at solutions for those challenges. So first of all, in terms of background, the guideline update was released last year in June to replace the previous guidance from 2017. Ovarian cancer is still the sixth most common cancer in UK females, but there have been changes in various of the characteristics, with the peak incidence having risen from between 60 and 64 at the time the previous guidance was written, up to 75 to 79 years now. One of the good news stories in ovarian cancer has been that the mortality rates have fallen over the last 50 years, with a particular increase in that decline. That's a bad way of putting it, sorry. More recently, but still equating to over 4,000 deaths annually from the data reported. The peak age for mortality for ovarian cancer is in the 85 to 89 year old age group, and there are various factors which are influencing how the kind of ovarian cancer landscape is changing, including things like increasing contraceptive use, increases in risk-reducing surgery, and evolving treatment options. There's also an acknowledgement in the new guidance around the need for accurate cancer registry data so that we can understand trends better. So a bit of background in terms of risk factors. So in terms of looking at hereditary risk factors, it's the kind of the data suggests that inherited factors contribute about 22% towards risk of ovarian cancer, with most of that accounted for by the BRCA mutations, and somewhere between 15 and 22% of ovarian cancers are caused by pathogenic variants in various cancer susceptibility genes. And together, all of those account for about 40% of the total heritable risk of ovarian cancer. Lynch syndrome is also associated with an increased lifetime risk, and it's the second commonest heritable cause of ovarian cancer, accounting for somewhere between 0.5% and 2% of cases. It is often diagnosed earlier and is less likely to metastasize, so does seem to be associated with better outcomes. There are various environmental factors. As I'm sure that you all know, increased number of lifetime ovulations is associated with increased risk. So things like nulliparity, early menarche, and late menopause are all associated with increased risk, whereas reduction in ovulation is associated with a lower risk, and things like oral contraceptive use, higher parity, and breastfeeding are all associated with reduced risk. We also know that salpingectomy and tubal ligation are associated with lower risk, and endometriosis is associated with an increased risk of low-grade serous endometrioid and clear cell carcinomas. There's an association between PID and borderline tumours, but not with invasive disease, and smoking is associated with an increased risk of mucinous tumours. So looking at this, I wanted to look at, are there updates which affect how we work in a cancer unit, and looking at all the changes that there are in the updated guidance. What I've focused on here are risk reduction, moving away from RMI as a diagnostic tool, the increased use of genetics to help guide treatment options, and a recognition of the value of prehabilitation before treatment. So the recommendations are, in terms of risk reduction, there's currently no role for screening of women who are considered low risk of ovarian cancer, and the role of ovarian cancer surveillance in women at high risk, while it's shown good performance and characteristics, there's no available data demonstrating survival benefit at the moment. Women who carry a pathogenic or a likely pathogenic variant in a high to moderate risk susceptibility gene should be offered informed counselling for bilateral risk-reducing salpingo-oophorectomy for ovarian cancer prevention once their family is complete. So that threshold is recommended to be around the 4 to 5% mark for lifetime ovarian cancer risk, and currently the risk-reducing salpingo-oophorectomy with or without hysterectomy is recommended depending on individual risks, genetics and patient preference. So within the guidance, the recommendations are that these patients should be reviewed by a specialist with support from an MDT, and it doesn't really tell us who an appropriate specialist is, but I would say it's likely to involve core members of your local MDTs and or other clinicians who are supported by the MDT. It's likely to involve some kind of workload increase. And I think one of the questions we need to answer is, can that be accommodated without compromising other local cancer services if we are managing that as cancer clinicians in a cancer unit? These aren't generally huge numbers of patients, but there's already increasing numbers of suspected cancer and cancer patients coming through my clinics, and really any increase in workload has the potential to cause difficulties in how that's managed. So thinking about how we can support people outside the MDT with managing women who come to have these discussions is important. Can local MDTs support that additional workload as well? I don't know what your MDTs are all like, but we used to have significantly lower numbers that we were discussing on our MDT, and while we've managed to mitigate that somewhat by trying to screen referrals and suggest that patients need kind of other things before being discussed, it's still adding more patients on to our workload can potentially be an issue. And also potentially there can be issues in terms of how that runs within the MDT, because our coordinators in Bolton are very busy and they end up covering lots of other tumour sites as well. And there's considerable pushback for discussing and coordinating cases which aren't kind of suspected cancer or definitely cancer. So I've included a table here from the guideline, which is certainly I found very helpful in terms of looking at the kinds of gene mutations and their associations with different cancers, and the recommendations in terms of surgery and the kind of age ranges which we're looking at of thinking about doing that surgery. So the next I was going to move on to was the ultrasound and diagnostic imaging, and the recommendation, as it has been before, was that CA125 forms part of your initial diagnostic pathway, along with ultrasound scan, particularly when you're looking at postmenopausal women presenting with symptoms of ovarian cancer. However, the recommendation is that RMI should be discontinued as a triage and a diagnostic tool in clinical practice, and the advice is that there should be a choice between either the Roma score or the IOTA ADNEX score with the thresholds I've put there as a replacement, depending on cost effectiveness and local resource implications. So we've been using RMI for a long time to help guide further investigations, further interventions, and to triage whether patients are managed either locally or in a cancer centre. But there are newer models which have got evidence showing that they're better, particularly for premenopausal women. The risk of ovarian malignancy algorithm, or ROMA, uses a combination of markers. However, it's the HE4 is not routinely available within the NHS, so isn't easily available to most of us. And IOTA, which has certainly been talked about a lot over the last 12 months and more, particularly in terms of the ADNEX score, which is based on ultrasound findings, which of course we all have access to. Which is best? So the Rockets study is looking at risk prediction models for ovarian cancer, compared with RMI at 250. The IOTA ADNEX score is significantly more sensitive, but with a lower lower specificity. Roma is also more sensitive, and without quite as much of a dip in specificity. However, on the recommendation from the paper, which I'll give you the reference for at the end, is that the IOTA ADNEX score looks like it's the standard we should be going with. Using IOTA is challenging because it requires both sonographers and gynecologists to be trained and to understand how it works. Particularly for the sonographers, they need to have formal training so that they know how to do the examination, how to report the findings so that it can be reliably interpreted and so that we can use those calculators such as ADNEX to generate these scores. It does provide additional challenges, particularly when you take into account that an awful lot of the ultrasound scans that we get reports for are from community-based ultrasound, which are providers that have contracts with GPs. So sometimes that could mean additional duplications of examinations to ensure that we've got adequate reports to base our decisions on. But it can be beneficial. It can be used in one-stop clinics, particularly where there are gynecologists who are have the skills for gynae scanning and can learn these skills and can manage that as part of a one-stop clinic. And I think from my memory, the numbers are about 3/4 of patients can be reassured and taken off the pathway at the first consultation with that kind of model. It can also help with resource management in terms of your CT and MR resources, that they're focused on people where we think that this is going to give us additional information. So in terms of genetics, it's probably one of the biggest areas of progress that we've seen since the last guideline. The recommendations in the updated guidance were developed from a consensus statement between the BGCS and the British Association of Gynae Pathology. And that is that all patients who are diagnosed with a high-grade epithelial ovarian cancer who have should be offered germline testing for BRCA, and those with advanced stage high-grade epithelial ovarian cancer should have tumour tissue tested for somatic mutations. And depending on where you are, that may be done already as part of reflex testing. And the rationale is to see whether additional treatment is likely to be beneficial. The consensus statement also mentions about the potential for offering testing at earlier stages, but that wouldn't affect treatment options. So I think the key to take away here when you're looking at offering testing is thinking about offering this from as early as you possibly can. And this is where, as a cancer unit, we can have a real impact in that we're thinking about this and mentioning it at an early stage and mentioning it to the people who it's recommended for. But that does potentially come with some challenges because we need to think about how we're going to offer screening. We need to ensure that the staff who are going to be discussing that are appropriately trained to go through consent for germline screening, germline testing, because certainly I know locally in Greater Manchester that the wait times for referrals for formal genetic counselling are long, even for more urgent cases, and it has a potential benefit for those services by us being able to take on that early part of the workload away from them, and they can focus on the people who really need to be seeing them. But it can involve, you know, wider members of the team than gynecologists. Certainly CNSs can be involved with that, but it's making sure that people have got the appropriate training, and I've put one here, which is the genomics education program, which is an accredited CPD program for giving the experience that you need for gaining consent for germline testing. In terms of prehabilitation, there's a recommendation that prehab should be structured and individualised, that it should include optimisation of nutrition and comorbidities, increase in exercise tolerance, management of psychological stresses and social support. And it's something which the members of the CNS team and cancer support workers are well placed to help with, and they can support those kinds of interventions. But again, it can come with challenges, and certainly in a lot of areas there isn't a single prehabilitation service where you can refer people. So it may be very dependent on the kinds of services that are available in local areas. It might be able to access some of that support, but not all of it. But it can be quite challenging to try and coordinate that and ensure that people get the intervention they need when they need it. Again, that corresponds to an increase in workload. And again, how does that impact the rest of the service? It does have potentially huge benefits for patients in terms of, particularly when it comes to things like surgery, where if they're not fit enough for surgery beforehand, it can bring people over the threshold for surgery. And if not, it will hopefully make the surgery safer for them. So, in summary, the new guideline published in 24 has much wider guidance about risk reduction, and talks about using newer algorithms to aid diagnosis, and that we should be discontinuing using RMI and using an alternative system such as IOTA ADNEX. There's new guidance for germline and somatic HRD and BRCA testing, and new guidance on prehabilitation as well. And that's it. Thank you.
I just had a quick question. So with regards to the suggestion of bringing people who require risk-reducing surgery through MDT, I mean, I don't know about everybody else's MDT, but in our MDT we've got a pathologist, a radiologist, we've got me, we've got a CNS, and that's it. What we don't have is a geneticist, we don't have a specialist in menopause, and so in our gynae-oncology MDT, I don't really see a benefit of bringing these patients through. And so my question would be, do you think it's feasible to have a risk-reducing MDT, and should that be being done at a regional or super-regional level rather than at a local level?
I suspect that you're right, because certainly I don't think we are always the best people to be the only people discussing these things, and that actually often it is quite a specialist discussion. And yes, absolutely, I think more regional MDTs would be beneficial, but certainly we don't have access to one at the moment. I don't know what it's like where you are. No.
I was just going to add something actually on that. Andy Phillips, I'm one of the gynae-oncologists from Derby, and I'm bizarrely run sort of a risk-reducing clinic about once a month. It's not a lot of people which come through. What I would say is what's really useful is having the familial cancer specialists involved so that they get a record of the genetic mutation and it's stored, because you'll get some people every so often who say they've got a BRCA mutation but haven't, but they do want their tubes and ovaries out. That's one trap. I haven't yet had a patient which would benefit from an MDT, because essentially you know what their risk is and you put their data into sort to work out what their surgical risk is, and then you give that information to the patient and take it forwards. And I haven't really had the situation where it's been a really difficult case, because often if they're really young, the familial cancer specialist can give you an up-to-date calculation of exactly how their risk for their mutation is going to be, just off relatively easily available bits and pieces. One big issue which is going to come, though, is that the thresholds have all been dropped for testing, and we're now finding loads of people which have got genetic mutations, and there's going to be absolutely tons of LAP BSOs coming through, and I think that is going to suddenly start filling up tons of theatalists, especially in the units.
Okay, my question is,
Sorry.
I just want to ask you, I have some cases like when they say postmenopausal ovaries, bulky ovaries, not with any cysts,
Yeah.
but borderline CA125 or normal CA125 levels. How would you manage them? So would you offer them surgery?
I think it depends on the whole situation. I mean, normally just having bulky ovaries with a borderline CA125 wouldn't often kind of prompt me to want to jump into operating on them. I think it's one of the things where things like IOTA can be very useful, because I think a lot of the problem that we get is somebody will comment, one sonographer might comment that there are bulky ovaries, and then another sonographer will not mention anything, looking at exactly the same ovaries. And the benefit that things like IOTA brings is that there's that uniformity with the reporting, so that we know that the things that are reported are significant and that they're useful in terms of calculating the scores. So I think that that's where hopefully it will be beneficial, in that we won't get as many ambiguous reports from a cancer perspective.
Yeah, in these cases, actually, they mentioned that there is no increased vascularity, but we had one case, and after, I think, would you advise repeat scans for them? Anyway, we have repeated, and the CA125 was like initially to start with, it was 20, and then the second one, it was after 3 months, it's gone up to 48. And then after 3 months, 200, and it was a cancer.
And that's
There's
where
no
it's sometimes
increased
difficult,
vascularity
isn't
on
it?
the
And
scan.
yeah, and sometimes there's that nuance in terms of, would you necessarily jump in and operate on somebody if they are, you know, very frail, versus somebody who's very fit and well, where you've got a concern. And I guess there's that potentially that role there where you can say, well, if we've got a concern, we can consider other imaging, or you can consider following things up as you have done. And have they had some surgery and a diagnosis, or?
Last question, thanks.
Thank you, Jonathan, for that wonderful presentation. Just a quick question. More and more in our MDT, local MDT, our radiologists are using the ORADS classification, and I kind of sort of missed whether it's part and parcel of the revised 2024 guideline, because we're finding it challenging for our sonographers to use the IOTA. Thank you.
Yeah, so it is mentioned. It does have some utility, and obviously it's used in a different scenario. Whereas the idea of the kind of IOTA and ADNEX is more around the IOTA ADNEX is more around helping kind of guide diagnosis initially, and then that for people with iota, if you have an equivocal result, there are some people who will then go on to have an MR, for example, and then ORAD. They do talk about ORADs in the guidance. It can be. I found it useful in terms of that there are numbers, particularly when you're counselling women about surgery and things like that, that if you look at kind of what an ORAD's 2 or 3 lesion and the risk of cancer and associated with that, it gives you a better way of counselling women about how you manage going forwards. But in terms of from an MDT perspective, I think it's I think I would always defer to the radiologists in terms of if they have concerns that a particular lesion appears malignant, that we would go on to discuss that at the sector MDT.
Thank you very much.